So the partial agonist concept for the dopamine type 2 receptor actually got a Nobel Prize in 2000. So it was not a small discovery, but quite a valuable one. And since then, uh, we have had multiple partial agonists. Actually, three of them are available now. And partial agonist concept was taken um, uh, so nicely is because partial agonist, if you want to know what does partial agonism means. So when a drug attaches to a receptor, it can result in multiple effects. One is the agonist activity, in which there is a activation of the receptor, um, and then there is an antagonism, which actually results in uh, uh, antagonism or the blockade of the receptor mediated actions. There is an inverse agonism as opposed to full agonism. Inverse agonism is actually more potent than antagonism, even because inverse agonism means that, for example, if there is a channel, sodium channel, on which suppose an inverse agonist attaches to the sodium channel and it blocks the channel completely, there's no passage of any electrolyte through that channel to change the action potential to result in the effects mediated by the receptor, right? Downstream. So inverse agonist is the most potent antagonist. So there is an inverse agonist, there is an antagonist, there is a full agonist, and then there is a partial agonist, right? So what does partial agonist means before we even talk about some of the medications which are partial agonists? Please remember this, because partial agonism is a very unique concept. And if you don't understand this well, you probably will not be able to understand why there is a big deal about partial agonism, not only just as D2 receptors, but so many different neurotransmitter systems have partial agonists. So partial agonist actually is not a good name for this action because it creates confusion. If you ask somebody, what do you understand by partial agonism? They will tell you that partial agonism means that it is not a full agonist. It only activates partially, right? That is the general concept, right? Which is completely wrong. Because a partial agonist, after attaching to a receptor, the action of a partial agonist depends upon the baseline activity of that system, neurotransmitter system. To give you an example, if a D2 receptor partial agonist attaches to the D2 receptors and the dopamine activity at the D2 receptor is high, it will bring it down. But if the dopamine activity is low, it will bring it up. So it can work either way. So you might as well call it a partial antagonist as well, right? So it creates confusion. The right word for a partial agonist is a system stabilizer, which brings balance in the activity of a neurotransmitter system. Isn't that beautiful, right? That is why there is a big deal about partial agonist. Now, if you look at the basic pathophysiological model of schizophrenia, you will see that schizophrenia has a lot of contradictions in terms of dopamine activity. Because in some areas, dopamine activity is high, and in some areas, dopamine activity is low. And if you remember from the 4 dopaminergic pathways, which I taught you last lecture, you will see that inhibition of dopamine receptors only in the mesolimbic area produce positive effects, that is, reduction in psychosis. But blockade of dopamine activity and the remaining three causes side effects. You remember that, right? I hope you do, because this is very important. So let's suppose that you give a partial agonist instead of full antagonist, right? Such as haloperidol or risperidone. What would happen? A partial agonist will still reduce dopamine activity in mesolimbic, but it is not going to affect much of the other three dopaminergic tracts. Why? Because partial agonist only works when there is an imbalance in the neurotransmitter system. As a matter of fact, if you look at in most schizophrenia patients, dopamine activity in the mesocortical area is low. So when you give a partial agonist, the most beautiful thing you can imagine, at least theoretically, is that a partial agonist will increase dopamine activity in mesocortical area. Why? Because it was reduced. And it will reduce dopamine activity in the mesolimbic area where it was increased. You cannot present a better hypothetical model of treatment of schizophrenia. So that is why there is a big deal about partial agonist. Again, in mesocortical area, there is existing deficiency of dopamine, so it will stimulate there. And in the mesolimbic area, there is increased activity of dopamine, so it will reduce it there. But remember, use this information cautiously. Why? It's not a perfect world. Even the partial agonists have different level of partial agonism, and we have not yet found what is the best level of partial agonism in individualized patients, because every patient may vary, right? So that is why partial agonists don't work in every patient. So remember this, despite the fact that it is a theoretically sound model, the patients are extremely variable. So there's no guarantee that this will work. But I have seen it clinically that when partial agonists work, like aripiprazole, it really works beautifully without giving much side effects. Why? Because it's a partial agonist. So those are the very important basic concepts about partial agonist. What are the three partial agonists we have approved, at least in America? I don't know. In Pakistan, I think you do have aripiprazole, right? And I think you do have cariprazine. And I think I don't know about brexpiprazole. Those are the three which are approved in America. So aripiprazole, brexpiprazole, and cariprazine. Those are the three partial agonists. Amisulpiride or sulpiride actually are not available in America. So I don't know whether you guys have those or not. So this is kind of a watch or a clock on which you can see where the antagonists lie and where the almost full agonist lie on this spectrum. So you see that aripiprazole, they are calling it almost antagonist, which is actually confusing. I think I should not show you this slide. It doesn't make it is very confusing. Okay, so here are the effects of aripiprazole. So aripiprazole actually is not only a partial agonist at dopamine type 2 receptors, but it also is a partial agonist at 5-HT1A receptors. It also blocks 5-HT2A receptors. All of those are quite desirable effects to have in a drug, right? Because you remember I told you the difference between typical and atypical antipsychotic medications? The typical ones are dopamine antagonist, but the atypical one are serotonin dopamine antagonist, SDAs, right? So 5-HT2A is the serotonin blockade by the second generation or atypical antipsychotic medications. So aripiprazole, just like other second generation antipsychotic medications, has a similar activity. But the unique things which it offers in addition or on top of second generation is the partial agonist rather than a full antagonist, and a partial agonist at both D2 receptors and another subtype of serotonin receptor, which is 5-HT1A. So this is quite nice. Okay, slides are. So these are the these are the receptor affinities for aripiprazole. And as you can see, there are multiple receptors affected by aripiprazole. At the bottom line, look at the D2 marker on the left side, second from the left. That is the potency for partial agonism at the D2 receptors. Right to that is lesser affinity for all the receptors on the right side. But on the left, there is bigger affinity 5-HT2B. Those are not important for discussion today, but you can imagine the reason I'm showing you this is that D2 receptor is much a partial agonism or attachment to the D2 receptor by aripiprazole is very potent effect. Let me close the door. Yeah, so if you look at the three partial agonists in terms of 5-HT2A binding, which is shown with the broken line, you see that aripiprazole versus brexpiprazole and cariprazine. It seems like brexpiprazole is quite similar to aripiprazole, but cariprazine has some other receptor effects which are more potent than D2 effects. So I'm not going to talk about dosages and interactions because we can separately talk about those things. But let's see. Yeah, the weight gain is a big issue, right? So aripiprazole, the weight gain, which is defined as 7% or more than 7% of weight gain, aripiprazole actually does that in 21%, brexpiprazole in 17%, and cariprazine in 34%. Akathisia. So akathisia is something which you need to remember with partial agonist. So the question is that if aripiprazole, cariprazine, and brexpiprazoles are all partial agonists, then why do we see EPS, right? Good question. So the answer is that, if you look at the neurobiological underpinnings of extrapyramidal symptoms, different type of extrapyramidal symptoms, you will notice that they may have different neurobiological basis. For example, if you give cogentin or anticholinergic medications to treat dystonic reactions or Parkinsonian symptoms for that matter, there is a response. But if you give anticholinergic medications for akathisia or even for tardive dyskinesia, there is hardly any effect. As a matter of fact, tardive dyskinesia can get worse with anticholinergic medication. So the point I'm trying to make here is that the partial agonists actually are only associated with akathisia. in a significant manner. I have not seen any acute dystonic reactions or tardive dyskinesia on a monotherapy with a partial agonist. There may be some case report, but I think there is something wrong with those case reports because partial agonist is highly unlikely to cause tardive dyskinesia. Um, so what is the reason why akathisia is there with partial agonist? And the other APS are not there. That frequently reported, right? Akathisia is something which gets better with beta blockers, propranolol, right? So unlike other EPS, like dystonic reactions, which are helped by anticholinergic medications, akathisia is not helped by those. It is helped by propranolol or a beta blocker. So I think that akathisia is a different animal altogether among extrapyramidal symptoms. And one of the reasons why akathisia occurs with partial agonist is because of effects on the sympato other monoamines other than and dopamine, such as norepinephrine, basically, or norepinephrine or dopamine to some extent. Sorry, the um, serotonin and norepinephrine. So that could be the reason why partial agonists at D2 receptor are still causing akathisia, because it is mediated by different system other than dopamine effects, right? Okay. It's important to know because somebody might ask you that you call that aripiprazole and other partial agonists are should not cause APS, but then why does akathisia occur? So there is an explanation for that. Okay, brexpiprazole was the one which came after aripiprazole, and I'm not, we don't have time to go into details of all these, but I just wanted to give you a basic concept because brexpiprazole is a little bit different than aripiprazole, and it has more intrinsic activity in causing partial agonist at D2 receptor, which actually may be a good thing. So I really, if you ask me personally, that which medication would you prefer if you had the choice between ARI and brexpiprazole, I would actually prefer brexpiprazole because it has a little bit more intrinsic activity on the D2 receptors. So I think those are the basic things you need to remember about these partial agonists. If you understand the concept of partial agonism, you have one half the battle in understanding very, very interesting mechanism of action with these drugs. Okay. So let me go to the other slide set because we don't have time to discuss all these things in detail. Let me. So let me open this one. Okay, share. Okay. Can you see this one?
Yes, sir, we can.
Okay. So let's talk about some of the interesting molecular targets for future antipsychotic, and some of them are actually not future. I did not tell you about another very exciting drug relatively recently approved, which is called lumateperone. And that the I don't know whether it's available in Pakistan or not, but if it is available, remember this medication, because I think it is one of the most novel mechanism of action, uh, um, and maybe the most exciting drug after partial agonists. So there are multiple targets. There are GABA drugs which can be used in treatment of schizophrenia. Um, Although it is not a novel concept, but some of you might know this, that when antipsychotic medications are not working optimally, you can actually um, add a GABAergic drug to enhance the effects of antipsychotic medications. And there are some studies which actually support that point of view. And one of those agents is the studies are with is Depakote or valproic acid. The valproic acid actually helps in two ways. Sometimes schizophrenia patients have bipolarity as well. And in that situation, giving Depakote or a valproic acid would be extremely helpful, because it is a treatment for bipolarity, right? On top of that, GABAergic drugs can actually reduce the excitotoxicity which is caused by excessive activity of glutamate at the NMDA receptors. And that can be extremely helpful, because GABA drugs can have neuroprotective effects because of that. So GABA drugs there is a new concept in GABA drugs, which is called the positive allosteric modulation of GABA A receptors. And positive allosteric modulation of GABA A receptor actually is an effect which has been shown to be effective in the treatment of postpartum depression as well as depression. So there is a recently a drug approved by FDA, brexanolone, which is a analog of allopregnanolone, which is the metabolite of progesterone, the female hormone. And that actually is the first approved treatment for postpartum depression. And the point of view behind that is that postpartum depression involves excessive glutamate activity. And this brexanolone suppresses that and is helpful. So I don't want to, we can keep on going on just talking about this GABA drugs, but let's move on. Glutamate modulators. So the glutamate modulators are very, very interesting. Remember, I don't know whether I told you this or not, but we have been missing the boat by not targeting these two most frequently existing neurotransmitter systems in the brain, because we had a narrow vision and we started targeting serotonin, norepinephrine, dopamine, right? They are, as compared to GABA and glutamate, are much less frequently involved in brain action than these two, GABA and glutamate. They are much less concentration in the brain than these two. Now, all these decades, we did research on monoamines, and now we have realized that the major targets in terms of neurotransmitter systems should be GABA and glutamate. And the funny thing is that glutamate and GABA actually make each other in the presynaptic neuron. The GABA is made from glutamate, and then glutamate again converts by enzymes and results in formation of GABA. So these two systems, one is inhibitory, one is excitatory, right? They are the most important systems, and the nature and the God has created this kind of a fine balance to maintain homeostasis in the brain function, that both of these drugs can actually, in normal circumstances, control each other's production and release. It's just fascinating. Brain sciences are just fascinating, as you can imagine. And then there is a new concept, not that new, but relatively speaking. Glycine is an amino acid you may have heard about. And cycloserine and serine are also the other amino acids. You know why I'm bringing them up here for discussion? Is because all these are involved in the function of GABA drugs. And actually, glycine also modulates glutamate activity. So these are kind of indirect targets to enhance antipsychotic effects. So we will talk about one of these drugs in the next few slides. So I'm not going to spend more time. mGluR. What is mGluR? The lowercase m, or the small letter m, stands for metabotropic. So there are two types of receptors. One is inotropic and the other one is metabotropic. So metabotropic receptors are G protein coupled reactions. And so glutamate receptors are both inotropic as well as metabotropic. So inotropic receptors, you already know, NMDA, AMPA, and kainate receptors are inotropic, which means that they have electrolyte channels through which the actions occur, right? The metabotropic receptors are much more complicated, and their effects are delayed and they take time to happen. So M is for metabotropic and GLU is for glutamate, R is for receptor. So mGluRs is metabotropic glutamate receptors, simply means that. So there are partial agonists for this receptor which are in development. And I don't have to tell you that why partial agonists are being sought. Remember what I said about the other partial agonist? Anti-inflammatory. I think you must have heard about this too, right? Anti-inflammatory drugs like curcumin, which is nothing but haldi, turmeric powder, is an active principle of that. Minocycline has been studied in schizophrenia. Aspirin has been, and celecoxib also has been studied as an augmentation strategy, not as a monotherapy, but as an augmentation strategy in schizophrenia. And so curcumin is one of the most potent anti-inflammatory, antioxidant agent we have known. So there are some studies, some evidence, but formal phase 3 trials are absent. I have submitted curcumin proposals many times. Unfortunately, I was not funded, but that does not mean that, the future, I'm sure some trials are going on even now. So curcumin is something which has anti-inflammatory augmentation strategy that can be added to antipsychotic medications. Minocycline is something which actually I was funded to do a large clinical trial when I was in Houston, but then I moved, so we had to give up that study to somebody else. So because I submitted and I got approval for that, but then I moved from there. Aspirin and celecoxib studies are also available. And with minocycline, I'll show you some data, which I have some slides on, because that is the most studied anti-inflammatory agent. Although it is an antibiotic, but it has very potent anti-inflammatory effects, okay? Antioxidants, the N-acetylcysteine, which is a very potent antioxidant, has also been studied as an augmentation strategy in schizophrenia. Gut flora. I don't have to tell you that gut flora play a very important role in all psychiatric symptoms. And dysbiosis, which is the abnormal presence of gut flora, actually is not helpful to any mental or other bodily functions, because it's just one unit. Whole body, human bodies are one unit thing. And gut flora actually has so much implication that you cannot even imagine, that they are part and parcel of our normal living, if they are normal, the flora are normal. Epigenetics. Epigenetics is a very, very interesting concept. And you probably will not even imagine that valproic acid actually has been really investigated, because the epigenetics, some of the mechanisms is methylation and deacetylation. So valproic acid actually affects the methylation process in epigenetics. And epigenetics is a really new kind of a concept where people are targeting treatment of schizophrenia, and valproic acid might give some insights into how long-term epigenetic changes via VPA or the valproic acid can enhance treatment of schizophrenia. And this is not the complete list, because I didn't have enough time to bring in some more, but I just wanted to give you some kind of information on some of the things which I just told you about. So, so there is this concept, even before we move to the individual mechanisms, there is this concept that some people actually support a multi-target approach for drug discovery in schizophrenia. And what does that mean? Is that you have either one molecule, or you combine different molecules with various mechanisms of action, and then achieve the desirable mechanisms which might be helpful in the treatment of schizophrenia. And it's very important to say here that schizophrenia is a syndrome. It has multiple symptom domains, right? But out of those, there are 3 core domains, which we, I think, discussed earlier. One is positive symptom, one is negative symptom, and the last but not the least is the cognitive symptoms. So far, we have the best response we have received in the treatment of schizophrenia is via the improvement of positive symptoms. We have not been successful in treating negative symptoms and the cognitive symptoms that effectively, as we have discussed earlier. So some of these multi-target approaches actually involve those symptom domains, which actually are much more robust predictors of functional outcome in schizophrenia than the treatment of positive symptoms. So that is the whole background. Now, these are some of the mechanisms which you can see here, which actually will tell you which will be desirable and which will not be desirable. So I don't want to go through all of them, but just for example, you have the muscarinic type 1 receptor antagonism and agonism almost in the middle of the slide. So we know that muscarinic type 1 receptor antagonism by cogentin or benztropine helps in EPS, decreasing EPS, right? But at the same time, it causes side effects: dry mouth, constipation, tachycardia, drowsiness, increase in cognitive dysfunction, right? So that is something which we don't want. But on the contrary, look at the M1 agonism, muscarinic receptor type 1 agonism. Decrease psychosis, decrease cognitive symptoms. So if you are targeting multi-target approach, you probably will pick something which is M1 agonist rather than M1 antagonist. I'll give you a fascinating example here. For example, clozapine is converted into norclozapine, which is its major metabolite, right? Norclozapine, unlike the parent compound, is a muscarinic agonist, not an antagonist. And there have been some researchers actually trying to develop norclozapine, but unfortunately, norclozapine is not as effective as clozapine in terms of psychosis. So the dreams have not come true, but I just wanted to give you an example, okay? So let's move on. These are some of the receptor affinities reflected by the plus sign. The more the plus sign, the higher the affinity, right? So chlorpromazine versus haloperidol versus some of the other drugs, just wanted to give you an idea that these are some of the affinities for different receptors. And from these targets, you can see based on the presenting symptoms of your patient, which will be desirable in terms of multi-target approach, right? So we don't have time to discuss this, but for example, if somebody is obese, already has metabolic syndrome going on, would you pick clozapine and olanzapine? No. At the same time, you look at aripiprazole, or if you look at ziprasidone. Ziprasidone actually is one of the best antipsychotic medications in terms of not causing so much problem with weight gain and metabolic syndrome. So you look here and you pick the drug based on the receptor action profile. And so in future development, you would like to see why ziprasidone is causing less effect on weight gain and metabolic syndrome. And then we'll try to incorporate that mechanism of action in a future molecule. And what is that? I think we can only speculate because there has been no research, but ziprasidone is a unique antipsychotic, which actually has one of the most potent effects at 5-HT1A receptor, which is not shown here, also 5-HT2A. But one of the reasons why it may be a little bit more weight neutral is because it has less effect on 5-HT2C receptors, which has been associated with long-term weight gain. And in addition to that, ziprasidone also blocks norepi reuptake pump and dopamine and serotonin reuptake pump, norepi and serotonin. And those are especially the norepi reuptake pump blockade, which is not as robust as some of the tricyclics or the SNRIs, but it is a meaningful effect clinically. So maybe that is the reason why, so there are multifactorial reasons why ziprasidone might not be causing that much of a weight gain, but you need to know that and need to incorporate those qualities, characteristics in future molecules. Now, this is let's see, this is lumateperone, which I was telling you earlier. Really a very novel, very interesting mechanism. I'll just tell you about it because we don't have time, but I'll tell you the mechanism so you understand what I'm talking about. So lumateperone is a drug which has a kind of a differential affinities for the presynaptic versus postsynaptic D2 receptors. As you know, D2, the presynaptic D2 receptors are autoreceptors. So if there is excessive release of dopamine in the cleft, the D2 presynaptic receptor will get activated and will put a brake on the release of dopamine because it is an autoreceptor. It causes negative feedback. I'm getting too much dopamine. Please stop it. So what is the effect of lumateperone on D2 receptor? It actually is a partial agonist at presynaptic D2 receptors, which means that If there is increased release, it will stimulate it. And if there is decreased release, it will inhibit it. That's what partial agonism means, right? So that is really fascinating because it controls, it stabilizes the release of dopamine from the presynaptic neuron. But what it does in addition to that is fascinating. It also blocks the postsynaptic D2 receptors, which help with psychosis. So this is a really phenomenal split effect or a differential effect on the D2 receptor. For the first time, we have seen this. And the implications are huge because, because if lumateperone is causing decreased release of dopamine through partial agonism from the presynaptic neuron, then you are going to require less postsynaptic D2 receptor blockade to have a meaningful antipsychotic effect. Again, I would say, repeat this. This is really very important for you to understand that lumateperone reduces the release of dopamine from the presynaptic neuron. So when dopamine is less, you actually need lesser D2 receptor blockade in the postsynaptic neuron to have a meaningful antipsychotic effect. And that is why lumateperone can only block 40% of the D2 receptor and be a meaningful, clinically useful antipsychotic medication. Never happened before. What is the implication for 40% receptor blockade, D2 receptor blockade postsynaptically? No EPS, no hyperprolactinemia, no cognitive blunting, no increase in negative symptoms, and so forth. So please ask me a question at the end because we'll leave about 5 minutes because this is an important concept. Partial agonism is also important, but this mechanism is also very important. These are some of the clinical effects. And this is one of the drugs which have been actually, because of its mechanism, has shown efficacy in both bipolar disorder type 1 and 2, as well as schizophrenia. So this is, I wanted to add some slides on this, but I didn't have enough time. But olanzapine has been approved with samidorphan. Olanzapine causes huge weight gain. Remember, we discussed that earlier, and I'm sure you know that. So olanzapine was combined with samidorphan. What is samidorphan? Samidorphan is a partial agonist at the opioid receptors. And so what happens is that we believe that olanzapine increases craving, especially for carbohydrates. And we think that opioid systems play important role in these food cravings. And so by modulating the opioid system, we wanted to show that olanzapine weight gain, if combined with samidorphan, can be reduced. And so this drug has been approved by the FDA. So olanzapine weight gain, it's not robust. It can be as much as 20 or 30%, but even that is quite good for patients who gain tremendous amount of weight on olanzapine. So a fascinating idea. Anti-inflammatory drugs, minocycline. So minocycline actually has been shown to decrease the pro-inflammatory cytokines, for example, IL-6 and high sensitivity C-reactive protein. And so those studies are available. And at the bottom, you will see all those studies showing some efficacy in various kinds of schizophrenia symptoms with minocycline. I'm not going to spend so much time on this again. This is, let's see, this is the latest study, which is randomized, the first large randomized control trial. And actually, it was kind of a negative study for, negative study for the negative or other symptoms. But I think I need to review this study because this was actually against the earlier findings. But I just wanted to show you the whole picture, because sometimes, what happens is that I remember this, that minocycline probably will be more helpful in patients who actually have elevated pro-inflammatory markers or cytokines. So if a study can look into a correlation between improvement in negative or cognitive symptoms of schizophrenia and also reduction in the pro-inflammatory cytokines, that will be a good study to see, because there is some evidence to support that only those patients with anti-inflammatory medications benefited benefit from anti-inflammatory drugs who actually have pro-inflammatory markers or cytokines. There is another, remember I told you about glycine? So the glycine, the point is to increase glycine, so it can perform co-agonist activities with the glutamate, to be helpful to schizophrenia, right? To improve schizophrenia symptoms. So glycine, there is a transporter. So we actually are doing studies right now in America in which glycine transporter is inhibited by this drug, which is only a number right now. There's no name given to it. And so that glycine can be increased and can be helpful to enhance glutamate activity in the areas where it is deficient. And this is, let's see. And similar is true for D-cycloserine and as well as serine. I didn't add those, but those are the same mechanisms which I just described you with glycine. NMDA receptor partial agonist, remember we talked about those. They can be helpful. And then this is the last one, very briefly. Ashwagandha is a Ayurvedic drug, very popular in India, and I'm sure in Pakistan, a lot of people know this one. Actually, there have been some studies showing ashwagandha was helpful in reducing schizophrenia symptoms, basically because, it has some desirable effects, such as anti-inflammatory effects, and it is especially useful in the treatment of stress and anxiety, and therefore may help. So a researcher from Pittsburgh, where I used to work before, Dr. Roy Chengappa, actually published a study. If you're interested, you can go and Google Chengappa and you'll find this study. You can read about it. So actually, so this ashwagandha, one of the natural products which can be helpful. So I'm going to leave some time for questions because we don't have much time left. Any
Yes, sir.
questions?
So I think we have only one in the chat. I'll read it out to you and then you can answer it.
Okay.
Javeria Ishaq asks, can weight be maintained by any means while on clozapine or any other drug causing metabolic syndrome? Or weight loss would be possible only by stopping the drug?
Yeah, that's a great question, because clozapine, unfortunately, is quite a dirty drug. It has a lot of side effects, but it is the most effective, or probably one of the very few treatments which are effective in treatment refractory schizophrenia. Right? You require blood monitoring, you require clinical monitoring, and there are problems with this drug. One of the huge problems is the weight gain and metabolic syndrome. So unfortunately, you always weigh between risk and benefits. If there is a schizophrenia patient who has no quality of life, cannot communicate effectively, does not becomes aggressive, agitated, family doesn't want to do anything with the patient, and the only choice you have is clozapine, and it works. Patient is gaining weight, but which one is the lesser evil of the two? That's your decision as a clinician. It should be an informed decision. You should discuss with the family, with the patient. A patient may not even respond to you logically, but again, it's your responsibility. But again, if you want to address clozapin's weight gain, there have been some strategies of which I'll mention only one at this time. I don't know whether semidorphan, which was attached, which was added to olanzapine, is available in Pakistan, but you can find out if you can add that and decrease weight gain, hopefully. But the most evidence is for metformin. If you want to give 500, maybe even 1,000 in some patients, that actually can reduce some of the weight gain. Any other questions?
Yes, we have another one in the chat by Atika Hashmi. Can you comment on current neurosurgical interventions for schizophrenia, like deep brain stimulation?
Yeah. Neurosurgical actually first alarmed me because I was thinking about lobotomies and we are past that period. Yeah, but you're right. Deep brain stimulation is a neurosurgical procedure. So I need to you need to calm down, right? Um, yeah. So so deep brain stimulation, unfortunately, has not been, as far as I know, there has been no research. There may be some individual cases, but it's so difficult to do DBS because even in depression, although we know that there are some really good results coming out, especially from Emory University in Atlanta, where there is this famous Dr. Mayberg, who has done most of those studies. It's very difficult to convince and get a consent from the family and the patient, and that's why the studies have been very small sampled. But there are some really encouraging news coming out for depression, not for schizophrenia. I'm not aware of.
I don't think we have any more questions.
Okay then. Okay then.
Uh,
Well, you're
okay.
when we do something in future, we'll see you guys, and let me know if you want some interesting topics to be addressed. There are hundreds and thousands of them, right?
Okay,
Thank you.
Abu Bakr,
Yes,
I
of
wanted to
course.
say something.
Yeah.
Okay, G, go.
Okay. Assalamu alaikum, Dr. Shad.
Walaikum assalam.
So I'm Dr. Atika here, and I just wanted to say thank you for providing us with very interesting insight on some of the current and possible future research avenues when
Yeah.
it comes to
You're
treatment
welcome.
about schizophrenia. Thank you
Yeah.
for being our teacher in last few days, and on the behalf of all KemPsych team members and medical students from KE and Pakistan, I really want to thank you for your time.
Yeah, you guys are almost always welcome because you can see that I love to teach. My goal is to create competent future psychopharmacologists. Psychopharmacology is not the beginning or end of all, but it is an important component of, yeah, especially during the acute phases of illnesses where you need these tools and you need to be completely aware of the underlying neurobiological aspects and receptor action mechanisms, so you can treat your patients effectively. Imagine if 20% of the whole comprehensive care of schizophrenia patients in this case is psychopharm, and because of your lack of knowledge you're approaching only 5% of that. That is disastrous. So yeah, combine everything together, not just use psychopharm, add everything: psychotherapy, physical activity, social activity, spiritual activity, and then you're going to get. Unfortunately, we don't have resources to do all that. But whatever we have, this is the best. You can learn psychopharmacology at least to discuss the about 20% kind of treatment for our patients, especially maybe more in acute phases, because acute phases, none of the other strategies will work. So you have to bring the patient to a platform where you can make further progress. Okay.
Yeah. Thank you very much.
Thank you so much. Bye bye.
Thank you, sir, for joining. Thank you for
You're
time.
welcome.
Thank you,
Yeah.
everyone, for joining. I hope you have a great day ahead. Allah Hafiz.
Allah Hafiz.